The worst pain you have ever experienced is produced by an organ that cannot feel pain. Your brain has no nociceptors, no pain receptors of any kind anywhere in its tissue. A neurosurgeon can touch the surface of a conscious patient's exposed brain during a wake craniotomy and the patient feels nothing. The organ that processes every pain signal from every part of your body is itself completely numb. And yet a migraine produces pain so severe it disables, sends people to dark rooms, to emergency departments, to decades of medication that stops working. Pain is real. The brain cannot be the source because it has no mechanism to feel its own pain. Something around the brain, in a space you have never been told about, is inflamed and screaming at a nerve. The brain sits in the middle, orchestrating the entire event, unable to feel any of it. The physics of how an organ with no pain receptors produces the most painful experience in medicine starts with a wave. And the wave is visible if you know what you are watching. Before the pain, a literal, measurable, physical wave of electrical activity propagates across the surface of the cerebral cortex at 3 to 5 millimeters per minute. A slow-moving front of neuronal depolarization followed by complete electrical silence was first recorded at Harvard in 1944 when Liao observed it propagating across exposed cortical tissue. It rolls across the cortex like a ripple on water. Ahead of the wavefront, neurons function normally. At the wavefront, neurons depolarize massively, firing in an uncontrolled burst that exhausts their energy reserves. Behind the wavefront, neurons are silenced, electrically dead for 15 to 30 minutes, unable to fire, unable to process information. When this wave passes through the visual cortex, which sits at the back of the brain and is frequently the first region the wave encounters, you experience the migraine aura. The shimmering crescent of light, the zigzag lines, the expanding blind spot, each is the wavefront rolling through the retinotopic map of the visual cortex, silencing the neurons that represent each successive portion of the visual field. The aura expands because the wave is moving. The zigzag shape corresponds to the architecture of the visual cortex. Orientation columns interacting with the wave to produce the characteristic geometric patterns you recognize instantly. If you have experienced a migraine aura, you have watched the wave crush your own brain in real time. The expanding blind spot was the wave's silence zone. The shimmering border was the depolarization front. The 20 to 30 minutes it took to traverse your visual field corresponds precisely to a wave moving at 3 to 5 millimeters per minute across the approximately 6 to 8 centimeters of primary visual cortex, slower than the minute hand of a clock. Visible because it is silencing the neurons that produce your visual experience as it passes. The wave does not appear from nothing. Cortical spreading depression requires a trigger, and the triggers are diverse, but the mechanism is singular. Cortical spreading depression requires a focal point where neuronal excitability crosses a threshold and the depolarization cascade initiates. The balance between excitatory and inhibitory neurotransmission tips toward excitation. Glutamate, the brain's primary excitatory neurotransmitter, accumulates faster than the inhibitory systems can contain it. A runaway depolarization develops. The wave radiates outward. What pushes the balance toward excitation? Sleep deprivation reduces GABAergic inhibition. The inhibitory brake weakens. Dehydration shifts the ionic environment around neurons, altering the threshold for depolarization. Hormonal fluctuations, particularly estrogen withdrawal in the menstrual cycle, modulate cortical excitability directly, which is why migraines are 3 times more common in women than men and often cluster around menstruation. Sensory overload, bright lights, loud sounds, strong smells, drives excessive glutamate release in the corresponding sensory cortex. Skipped meals drop blood glucose, reducing the ATP available to maintain the sodium-potassium pump that keeps the membrane potential stable. Each trigger has a different biochemical pathway. All converge on one outcome, a focal point where the excitation-inhibition balance fails and the wave begins. If you have identified your personal triggers, stress, missed sleep, certain foods, hormonal timing, you have identified the specific inputs that push your cortical excitability past the threshold where the wave initiates. Ice cream headache, brain freeze is the fastest accessible demonstration of an identical pain pathway to migraines operating on a compressed timescale. When cold contacts the palate, the sudden temperature drop triggers rapid constriction of the blood vessels in the roof of the mouth, followed immediately by reactive dilation, a vascular rebound that stretches the vessels and activates the trigeminal nerve fibers innervating them. The pain is referred to the forehead through the trigeminal pathway, identical nerve, identical central processing, identical location of perceived pain. Brain freeze resolves in 30 to 60 seconds because the cold stimulus is brief and the vascular rebound is transient. A migraine is this trigeminal vascular activation sustained for hours by the CGRP-driven inflammation rather than resolving in seconds. The mechanisms are identical. The duration differs because the driving stimulus differs, a transient temperature change versus a sustained chemical cascade. Sleep and migraines operate in a bidirectional relationship that makes the condition self-reinforcing when sleep is disrupted. Poor sleep reduces GABAergic inhibition, lowering the cortical excitability threshold and making the spreading depression wave more likely to initiate. The migraine itself disrupts sleep, the pain fragment sleep architecture, reduces deep sleep, and produces the postdrome fatigue that shifts sleep timing. The shifted sleep timing further disrupts circadian regulation of cortical excitability, which increases vulnerability to the next migraine. The cycle feeds itself. Poor sleep triggers migraine. Migraine disrupts sleep. Disrupted sleep lowers the threshold for the next migraine, breaking the cycle at the sleep point. Maintaining consistent sleep timing even after a migraine day. Avoiding the compensatory sleeping in that shifts the circadian clock is one of the most effective threshold management strategies because it interrupts the self-reinforcing loop at its most accessible point. Hormonal migraines deserve specific depth because the mechanism explains patterns that many women have observed for decades without understanding why. Estrogen does not trigger migraines while it is high, it triggers them when it falls. The cortical excitability threshold is modulated by estrogen levels. High estrogen increases serotonin availability and GABAergic tone, raising the threshold and making the spreading depression wave less likely. The days before menstruation, when estrogen drops sharply, remove this protective modulation. The threshold drops, the excitation-inhibition balance shifts toward excitation, and the wave becomes more likely to initiate. Pregnancy often reduces migraines dramatically because estrogen remains high throughout. The threshold stays elevated for 9 months. The postpartum period, when estrogen crashes, often produces severe migraine recurrence. Perimenopause, when estrogen levels become erratic, high 1 week, low the next, without the predictable cycling of reproductive years, produces the most unpredictable migraine pattern because the threshold fluctuates with the hormonal instability. Postmenopause, when estrogen settles at a consistently low level, many women find their migraines improve. The threshold is consistently lower, but the fluctuations that trigger the wave have stopped. You now know what the wave is and what starts it. The question changes from what happens in the brain to how an organ that cannot feel anything produces pain that disables. Well, the meninges, because this is where the pain actually lives. Brain cannot feel the wave. The brain cannot feel anything. But the meninges, 3 membranes wrapping the brain, can. Dura mater, the outermost membrane, is densely innervated by the trigeminal nerve, the largest cranial nerve responsible for sensation from the face and head. The trigeminal fibers in the dura are nociceptors, pain receptors. The brain has none. The membrane surrounding it has thousands. Between the meninges run cerebral blood vessels, arteries and veins that supply and drain the brain. These vessels are also innervated by trigeminal nerve fibers that wrap around them like vines around a trunk. When the vessels dilate, stretch, or become inflamed, the trigeminal fibers fire pain signals. Cortical spreading depression, as it propagates across the cortex, releases potassium ions, ATP, and inflammatory mediators into the extracellular space. These molecules diffuse through the thin pia mater and reach the dura. The dural trigeminal fibers activate and release neuropeptides, primarily calcitonin gene-related peptide, CGRP, from their terminals around the meningeal blood vessels. CGRP dilates the meningeal vessels. the pathway Edvinson established across 3 decades of trigeminal research at Lund University. The dilated vessels become permeable. Plasma proteins leak into the surrounding tissue. Mast cells in the dura degranulate, releasing histamine and more inflammatory mediators. Neurogenic inflammation develops, a self-amplifying inflammatory cascade in the meninges, driven by the trigeminal nerve's own neuropeptide release rather than by infection or injury. Pain is the inflamed, swollen, distended meninges pressing on and stimulating the trigeminal nociceptors that innervate them. The brain, sitting inside the inflamed membranes, causes the inflammation through the wave but is unable to feel it. The paradox resolves, the pain is real, the location is the meninges, and the brain, which started the entire cascade, is the one structure in the skull that is numb to its consequences. Pressing your temples during a migraine and feeling slight relief, you are compressing the superficial temporal artery, a meningeal vessel branch, and transiently reducing the vessel distension that is stimulating the trigeminal nociceptors. The relief is mechanical, reducing the diameter of an inflamed vessel that is pressing on a nerve that the brain told to inflame in the first place, and then the throbbing. Because the rhythmic pulsation synchronized with the heartbeat is arterial physics translated into pain. Each cardiac systole sends a pressure wave through the arterial system. In normal vessels, the pulse wave produces no sensation. The vessel walls stretch and recoil without activating nociceptors. In inflamed meningeal vessels, where CGRP has dilated the walls, where plasma proteins have leaked, where the trigeminal fibers are sensitized by the inflammatory milieu. Each pulse wave stretches the already distended, already inflamed vessel wall. The sensitized trigeminal fibers fire with each stretch, 1 throb per heartbeat. You can feel your own pulse in your head. The arteries wrapped in inflamed membranes transmitting each cardiac cycle as a nociceptive signal through the trigeminal nerve. Physical exertion worsens migraine pain because exercise increases heart rate, increases systolic pressure, and increases the amplitude of the pulse wave, each amplified pulse stretching the inflamed meningeal vessels further. Bending forward and feeling the pain intensify, increased hydrostatic pressure in the cranial vessels from the head-down position, further distending the inflamed arteries. The physics is fluid mechanics. Pressure, flow, distension. Operating on vessels that have been rendered painfully sensitive by a chemical cascade, the brain initiated but cannot feel. Light sensitivity, photophobia, during a migraine has a specific neural pathway that explains why even dim light becomes unbearable despite the pain originating in the meninges rather than the eyes. The trigeminal vascular system, the trigeminal fibers that are firing from the meningeal inflammation, converges with visual pathway neurons in the posterior thalamus. These convergence neurons respond to both trigeminal pain input and retinal light input simultaneously, as Noseda and colleagues demonstrated at Harvard. During a migraine, the trigeminal firing sensitizes the thalamic neurons, and any light reaching the retina produces additional activation in neurons that are already firing from the pain signal. The light does not worsen the meningeal inflammation. It amplifies the pain signal at the thalamic relay station where the visual and pain pathways intersect. Darkness reduces the light input to the sensitized thalamic neurons, reducing the total firing rate, reducing the pain. The dark room is a thalamic intervention, reducing one of 2 inputs to a relay station that is already overloaded from the other. Sound sensitivity, phonophobia, operates through an analogous convergence. Auditory processing neurons in the brainstem share connections with the trigeminal nucleus, and the sensitized trigeminal system amplifies the perception of sound intensity. Sounds that are comfortable at normal sensitivity become painful during a migraine because the trigeminal activation has lowered the threshold at which auditory input produces a discomfort signal. The quiet room and the dark room serve one purpose: reducing sensory inputs to convergence neurons that are already hyperactivated by the meningeal inflammation, allodynia, the experience of pain from stimuli that normally do not cause pain, develops in approximately 2/3 of migraine sufferers during an attack. Brushing hair becomes painful. Wearing glasses hurts where the frames touch the temples. Resting the head on a pillow produces aching at the contact points. The mechanism is central sensitization. The sustained trigeminal firing from the meningeal inflammation sensitizes the second-order neurons in the trigeminal cervical nucleus to the point where they begin responding to inputs from skin mechanoreceptors, touch receptors, that they normally ignore. The touch signal, which would normally be filtered out at the nucleus, passes through to the pain processing centers because the nucleus has lowered its threshold for all incoming centers, because the nucleus has lowered its threshold for all incoming signals. Allodynia is a clinical marker of how far the central sensitization has progressed. Its presence indicates that the trigeminal nucleus has been firing long enough to sensitize beyond the meningeal input, and it predicts that triptans and other acute medications will be less effective because the sensitization has moved from the peripheral nerve terminals to the central processing centers. Prodrome, the hours or day before the migraine arrives, is the brain signaling that cortical excitability is approaching the threshold. Yawning, food cravings, mood changes, neck stiffness, difficulty concentrating, frequent urination. These are not triggers. They are early symptoms produced by the hypothalamic and brainstem changes that precede the cortical spreading depression. The hypothalamus, which regulates appetite, sleep, mood, and autonomic function, is showing altered activity hours before the wave begins. The viewer who says, "I always crave chocolate before a migraine," has been blaming the chocolate as a trigger when the craving was actually the prodrome. The brain's appetite centers signaling the neurochemical shift that was already underway. Postdrome, the hours or day after the pain resolves, is the brain recovering from the metabolic exhaustion the wave produced. Fatigue, difficulty concentrating, mood depression, and a fragile sensitivity to stimulation reflect the cortical neurons that were silenced by the spreading depression, slowly restoring their metabolic reserves. The migraine hangover is real and physiological. The neurons behind the wave were electrically dead for 15 to 30 minutes and require hours to fully restore the ionic gradients and neurotransmitter stores the massive depolarization depleted. The recovery is metabolic, and the fatigue during the postdrome is the brain conserving energy while the restoration occurs. Caffeine interacts with migraines through a dual mechanism that explains why it both helps and harms depending on the pattern. Caffeine constricts cerebral blood vessels through adenosine receptor blockade. It blocks the adenosine receptors on the vessel walls that promote dilation, producing vasoconstriction that reduces the vessel distension the trigeminal nociceptors are detecting. This is why caffeine is included in many migraine medications and why a strong coffee at the onset of a migraine sometimes aborts the attack. The vasoconstriction counteracts the CGRP-driven vasodilation. But regular caffeine consumption produces adenosine receptor upregulation. The vessels develop more adenosine receptors to compensate for the blockade. Caffeine withdrawal allows all those upregulated receptors to respond to adenosine simultaneously, producing a rebound vasodilation that is more extreme than the baseline. The weekend migraine, the headache that arrives on Saturday morning when the weekday coffee schedule is delayed, is caffeine withdrawal vasodilation triggering the trigeminal nociceptors in someone whose cortical excitability threshold was already near the wave. Initiation point. Barometric pressure changes interact with the migraine mechanism through a physics most sufferers have noticed but cannot explain. When atmospheric pressure drops before a storm during weather fronts, the reduced external pressure on the cranial vasculature allows the vessels to expand slightly. In a sensitized trigeminal system, even this modest expansion is sufficient to push the meningeal vessel distension past the nociceptive threshold. The viewer who says, "I can predict the weather by my migraines," is detecting barometric pressure changes through the trigeminal innervation of the meningeal vessels. The pressure drop produces just enough additional vessel expansion to trigger the pain in a system that is already close to threshold. Migraines change character with age in ways that reflect the underlying mechanism shifting rather than the condition simply worsening or improving. Many women experience significant reduction in migraine frequency after menopause. The estrogen withdrawal trigger that produced menstrual migraines is eliminated when the cycling stops. But some develop new migraine patterns driven by the vascular stiffness and reduced nitric oxide availability that accompany aging. The meningeal vessels become more reactive, less compliant, and the CGRP-driven dilation produces disproportionate nociceptive activation in stiffer vessels. Migraine with aura may increase in frequency in older adults, even as migraine without aura decreases. The cortical excitability threshold shifts with age in ways that favor the spreading depression mechanism over the purely trigeminal vascular mechanism. Now, the neck. Because the connection between neck tension and migraines is specific anatomy, and the walking discussion described the physics that feeds it. Trigeminal cervical nucleus. Located in the upper cervical spinal cord at the first through third cervical vertebrae, receives input from two sources: the trigeminal nerve carrying sensation from the meninges and head, and the upper cervical spinal nerves carrying sensation from the neck muscles, cervical facet joints, and upper cervical ligaments. Both sets of fibers terminate in one nucleus, as Botch and Goadsby documented. The second-order neurons cannot distinguish the source. A signal from an inflamed meningeal vessel and a signal from a tense suboccipital muscle activate the same neurons. STEP's discussion described how forward head posture multiplies the load on the cervical spine by a factor of 3 to 4, 5 kilograms becoming 20 at moderate forward tilt. That sustained cervical loading feeds the trigeminal cervical nucleus from below. The viewer whose migraines consistently follow periods of sustained neck tension, prolonged desk work, forward head posture, sleeping in a twisted position, may be triggering the trigeminal cervical pathway from the cervical input rather than from cortical spreading depression. The convergence also explains why migraines produce neck pain even when the neck was not the trigger. The meningeal inflammation activates the nucleus, and the nucleus sends signals back to the neck muscles through reflex arcs, producing tightness that feels like a neck problem. The neck and the meninges share a processing center, and input from either produces the output of both. The medication trap turns episodic migraines into daily headaches, and the mechanism is the reason breaking the cycle requires getting worse before getting better. Taking pain medication for migraines more than 10 to 15 days per month risks medication overuse. Headache. A condition where the treatment increases the frequency of the headaches it was prescribed to treat, as Diener and Limroth documented in Lancet Neurology. The mechanism is nociceptive system upregulation. The pain processing system in the brainstem operates with a baseline sensitivity threshold. When medication repeatedly suppresses nociceptive transmission, the system compensates by increasing its sensitivity, upregulating pain receptors, increasing pronociceptive molecule expression, lowering the threshold for pain signal transmission. The system is attempting to maintain its ability to detect genuine threats despite the pharmacological suppression. Result: a lower pain threshold when the medication wears off. The migraine that required severe pain intensity to break through a baseline now breaks through at moderate intensity because the threshold has dropped. Another dose, further upregulation, lower threshold, more headaches, more medication. A positive feedback loop that produces daily or near daily headaches, a frequency that never existed before the medication became frequent. The headaches are no longer purely migraines. They are a hybrid, the original migraine trigger plus the medication-induced threshold reduction producing a chronic pattern. The medication is now maintaining rather than treating. Stopping the overused medication produces a rebound period of 1 to 2 weeks where headaches intensify before the nociceptive threshold recalibrates upward. The viewer must get worse before getting better, which is why the cycle is difficult to break without medical guidance. But the physics is clear. The medication that was suppressing pain was simultaneously training the pain system to produce more of it. The nociceptive system responded exactly as any adaptive system responds to chronic suppression, by increasing its sensitivity until the suppression no longer worked. That feedback loop, the medication lowering the threshold that produced the headache that demanded the medication, is the cycle I wish had been explained to every patient before the prescription count reached 15 days a month. And then, what the physics points to, because each mechanism has a corresponding intervention that targets it specifically rather than suppressing pain broadly. Excitation-inhibition balance. Adequate hydration maintains the ionic stability that keeps the threshold away from wave initiation. Consistent sleep timing maintains the circadian regulation of cortical excitability. The migraine after a late night is reduced, GABAergic inhibition, leaving the cortex vulnerable to the spreading depression wave. Regular meals maintain the blood glucose that fuels the sodium-potassium pump. These are threshold management interventions, keeping the excitation-inhibition balance away from the tipping point rather than treating the pain after the wave has already started. Cervical pathway, head alignment, ears over shoulders, chin parallel to the ground, reduces the cervical muscle loading that feeds the trigeminal cervical nucleus. Reducing the cervical input reduces the probability that the convergence nucleus produces a migraine pattern output. The viewer who corrects forward head posture during sustained desk work is reducing input to the pain processing center that their migraines activate. CGRP pathway, the newest class of migraine-specific medications. CGRP monoclonal antibodies such as erenumab, fremanezumab, and galcanezumab target the specific molecule that produces the meningeal inflammation. They block the neuropeptide the trigeminal nerve releases around the meningeal vessels. This is the first migraine treatment that addresses the mechanism rather than suppressing the pain system broadly, targeting the CGRP that dilates the vessels rather than silencing the nociceptive system that detects the dilation. Distinction matters because CGRP blockade does not trigger the nociceptive upregulation that broad pain suppression produces. The medication overuse cycle does not develop because the pain system is not being suppressed. The inflammatory trigger is being blocked. Migraine with aura carries a specific vascular consideration you should discuss with your physician. The cortical spreading depression that produces the aura may temporarily affect cerebral blood flow in ways that interact with vascular risk factors, and the combination of migraine with aura and certain hormonal medications requires clinical assessment of the risk-benefit balance. Children and grandchildren of migraine sufferers deserve a specific mention because the genetic component is strong and the threshold management that prevents the wave is relevant before the first migraine arrives. If migraines run in a family, the children likely inherited a cortical excitability threshold that is lower than average. The same triggers: sleep deprivation, dehydration, skipped meals, sensory overload push their cortex toward the wave initiation threshold more easily. Teaching the threshold management early, consistent sleep, adequate hydration, regular meals may keep the excitation inhibition balance away from the tipping point and prevent the first episode from establishing the sensitization pattern that makes subsequent episodes more likely. That cascade, a wave crossing the brain at 3 millimeters per minute that the brain cannot feel, triggering a chemical inflammation in the membranes the trigeminal nerve has rendered painfully sensitive, the neck contributing through a convergence, nucleus that cannot distinguish meningeal signals from cervical ones, and the medication that was supposed to help training the pain system to produce more pain stopped me from calling it just a headache the moment the meningeal physics replaced the mystery. An organ that cannot feel pain, orchestrating the most painful experience in medicine, starting a wave it cannot sense, triggering an inflammation it cannot detect. In membranes it is wrapped inside. Through a nerve it shares with the neck it sits on top of. The brain started all of it, shares with the neck it sits on top of. The brain feels none of it. And the medication that was supposed to quiet the pain was teaching the system to amplify it. Physics was always there. The paradox resolves not by finding pain receptors in the brain, there are none, but by finding the pain where it actually lives, in the membranes, in the vessels, in the nerve that wraps around both, one pulse at a time.